Good morning, everybody. Thank you for the opportunity to speak to you today, and also to Debbie's Dream Foundation for supporting our patients, our caregivers, as well as our clinicians and researchers. My name is Rich Tuli. I'm a radiation oncologist. I'm the worst different doctor from Cedars-Sinai. I specialize in treating GI cancers, and I'll be talking to you today about the use of radiation therapy when it's appropriate to use for patients who have gastric cancer that has been removed, as well as some ways in which we're learning to both optimize our clinical outcomes, but also ways in which we are minimizing toxicity, which I think is equally as important. So what is radiation? Radiation is essentially high-energy X-rays that ionize cells. They're effective in killing cells, and unfortunately, not only do they kill tumor cells, but they can kill normal cells also. And they do this by disrupting atomic bonds in cells and causing damage to DNA. Fortunately, we are able to preferentially kill our tumor cells relative to the normal cells by giving small doses of radiation each day. So for those of you who have familiarity with radiation, you know that we spread it out over the course of 5 to 6 or even more weeks. And that is because the radiation will preferentially damage the tumor when it goes where it's supposed to go. And the normal cells will then have the 24 hours in between to recover. So you heard very nicely from Dr. Wu about patterns of spread of gastric cancer. And this is important not only to the surgeon, but also to the oncologist, both the radiation oncologist and the medical oncologist. She talked about cancers growing through the walls of the stomach tumors. And so it's important to us because they can often grow into other organs. They can start to involve blood vessels. And once they get to that point, they start to spread to the lymph nodes, in particular the regional lymph nodes, which are the ones around the stomach. And then, of course, given enough time, they'll start to spread to the peritoneum and get into the bloodstream and go elsewhere. This is a bit of a busy slide. We'll have several medical oncologists talking today about chemotherapy. This is a slide I used a few years ago giving a similar talk. But suffice to say that we have lots and lots of studies that have looked at the use of chemotherapy after surgery. And if we focus in on the bar that was to the rightmost panel, you can see that the vast majority, if not all of these studies, really have not shown a benefit to giving chemotherapy after surgery. And this has generally been the case both for chemotherapy and for radiation, but we are starting to see better results as our surgical techniques, including robotic surgery, have improved how these tumors are removed. So what is the case for radiation given after surgery? This was initially investigated back in the early 50s and 60s. A lot of the data came out of the University of Minnesota. Dr. Wangerstein essentially developed a process by which patients would undergo a second look surgery about 6 to 9 months after their initial surgery. So these are patients with stomach tumors. They had their initial surgery where part, if not all, of the stomach was removed. And then they would either go in for a second look scheduled at 6 months, or if they became symptomatic. And you can see in that second column there the number of patients who ended up having recurrence of disease at some point during that second look was overwhelmingly high. And so what we sort of drew from these studies was that that surgery alone likely led to inadequate control for gastric cancer. And if you delve into the details a little bit more, if you look at where these cancers tend to come back, not only do they come back locally, that is where the original tumor was, or regionally in the lymph nodes close by, but the vast majority will fail at some point in other places of the body. If you break down the data a little bit more and look specifically at those patients who have cancer that comes back where it was originally removed, the vast majority will come back either in the gastric bed, so that's the space where the tumor was removed, at the anastomosis, so that's where the two portions of the gut are sewed back together once the stomach has been removed, or in the lymph nodes. So a very bright gentleman, Dr. Len Gunderson, put together essentially a map, and this was developed back in the early 80s, looking at where these cancers came back in the body, locally and regionally. And so this was data that came from about 107 patients from the University of Minnesota, and this map essentially outlined what the radiation portal would look like. That is, this is the area we're going to target with radiation because this is where we think these cancers are most likely to come back. So I'm not going to bore you with too much data, but I think it's important to know where our treatment recommendations come from. This was one of the first studies that was done that came out of Britain that looked at 400-some patients who got surgery and then were given either radiation or chemotherapy. And suffice to say, unfortunately, there was no survival difference between any of the groups. So the chemotherapy and the radiation, unfortunately, contributed not to improving outcomes in these patients. This is a study that we tend to hang our hat on most often as radiation oncologists because it provides us the evidence that tells us that radiation, when given with chemotherapy, is beneficial and helps our patients live longer. This was a large study of close to about 600 patients that underwent curative surgery, and then, I think the slide got cut off a little bit here, but then they were either given no additional therapy, that's observation at the bottom, or they were given a 6-month course of chemotherapy in combination with radiation. And overall, the clinical outcomes certainly are not great, and they have since gotten better, but the addition of chemotherapy and radiation following surgery certainly allowed these patients to live longer, do better, and it kept the cancer away. If we delve into the details a little bit more and look at where these cancers came back, that's the failure pattern. If you look at the local and regional recurrences, you can see that with the treatment, these were substantially reduced. So the chemotherapy and radiation were decreasing significantly the likelihood that those cancers were going to come back where they originally were. Unfortunately, if you look at the distant recurrences, they weren't too different, perhaps suggesting that we need to do a better job with our chemotherapies. There are lots of critiques of this study. This is a slide that is more intended for our surgeons and medical oncologists, so I don't get beaten up after my talk. The big criticism with this study, actually there were two. The first being that the surgeries in more than half of the patients did not remove any lymph nodes. So the radiation was compensating for inadequate surgery. But I think just as importantly, and specific to radiation oncology, this was one of the first studies where they did a central review. So when we do our radiation therapy plans, we're sort of left to our own vices. We design our plan, nobody sees them, there's really no oversight as to what we're doing and how we're doing it. And in this study, they had all the treatment plans developed by the radiation oncologists reviewed. And quite surprisingly, more than a third of all the treatment plans developed by the radiation oncologists had either a major or minor deviation from protocol, suggesting that this complex treatment really perhaps wasn't being given the way that it was supposed to be. I think it sort of highlights the challenges with treating this difficult cancer. So what about if you have an adequate lymph node resection? Dr. Wu talked about D2 resection a little bit, which really means that along with taking out the entirety of the tumor and portions of the stomach, you take out lots of lymph nodes. This was a study that came out of Korea, about 1,000 patients, and here, similar to the prior study, patients after surgery either received no treatment or they got a similar regimen of 6 months of chemotherapy with radiation. And you can see in the red table down at the bottom that the patients who got the chemotherapy and radiation after surgery certainly lived a lot longer, and the cancer stayed away and was less likely to come back in the majority of cases. And this, again, a busy table, but shows that stage for stage, these differences held. So the chemotherapy and radiation was beneficial. And again, I'll point you to that bottom table there that looks at patterns of failure, where these cancers are coming back. With the chemotherapy and radiation, they were much less likely to come back where they originally were. So certainly good data that tells us that we're doing a better job. I think this is the last study that I'll present, but this is really the study that right now tells us when a patient should be getting radiation after surgery. This was a large study. It was done also in Asia, several hundred patients who got surgery and chemotherapy, which is the XP in arm 1, or XP and radiation in arm 2. So it was a study really designed to look at whether radiation was beneficial. Unfortunately, the addition of radiation did not improve the likelihood that these cancers were going to return unless you had lymph nodes positive. So our current standard of care, our current practice is that if you have a gastric cancer, you have it removed, if you have a lymph node positive, one or more, then you likely should be getting radiation after your surgery. So a little bit of historical perspective on how radiation has evolved over the years. I showed you that map from Dr. Gunderson early on. Back in those days and up until the early 90s, we were essentially using X-rays to help delineate how our radiation was to be delivered. So this is an X-ray here. You can see, and the bones, which you can see sort of running up and down, that's the spine there, were used as landmarks to help guide where the radiation was to go. Not a very accurate landmark, and you can certainly make some assumptions regarding ability or inability to accurately target the tumor and maybe lots of normal tissues around the tumor that are seeing radiation that they probably shouldn't be seeing. As we've integrated CT scans into how we deliver radiation, it's certainly gotten better. You can see outlines of organs there. The big organ there to your left is the liver, and then we're able to outline the stomach and the kidneys and the spinal cord so that we can better help delineate where our radiation is supposed to go and try to protect those normal tissues. But you can still see that initial port, which is probably smaller than that map I showed you in the beginning, still encompasses a lot of the normal tissues, and that's where the toxicities and side effects come from radiation. With the advent of newer technologies, this is something that we use at Cedars typically for all of our gastric cancer patients. You can imagine that when you breathe, your stomach, or what you have left of your stomach and your guts, move up and down. And that means tumors move up and down, and lymph nodes move up and down and in and out. And that makes it certainly challenging to target with radiation. We have the capacity now to be able to track tumors as they move as a function of breathing, so you can actually see them. You can see where they move. You can measure how much they move. And in this case, the top line represents the breathing, and the bottom line represents the radiation being either on or off. And so we typically will deliver radiation only when the patient has fully exhaled. And so we can do that automatically. And during that time, the tumors are not moving. We also integrate a lot of imaging into how we design our radiation plans. This is a slide looking at different types of MRI as well as PET scans. to help not only delineate where these tumors are and to help better guide how we deliver our radiation, but also to be used to determine whether our treatments are working. So there's a lot of new research coming out of our institution and others looking at early response assessment. So rather than waiting 6 months to see if a treatment worked, use an imaging modality such as PET scan after a few weeks of treatment to determine whether it works and whether or not we're going to abandon that treatment or continue on with something that's going to be successful. So this is really modern day treatment. This is one of my patients who has had a portion of the stomach removed, the distal gastrectomy, and this is a CT scan, and you can see the pink shading in between the lines represents the areas that we consider to be at highest risk for recurrence based on the data that I presented to you previously. And the yellow line that is outlining the pink represents 100% of the dose. So we are able to really wrap our radiation dose around the area where we want it to go and really minimize dose to all the normal tissues around the tumor. Certainly, it's still a very toxic regimen. We've got to do better, but we've made significant improvements in how our radiation is delivered. So just to conclude, surgery is the gold standard. We certainly need to do more. Radiation with chemotherapy has been shown to decrease the likelihood of the cancer coming back, not only where it originally was, but also in the lymph nodes. This is probably most helpful for patients who had lymph nodes involved from the get-go. Improvements in targeting not only allow higher doses to be delivered to the tumor, but they also allow reduced rates of toxicity. Higher focus doses of radiation, called stereotactic radiation, which I didn't really touch upon, are still being investigated in stomach cancers, but are being used routinely for lung and liver cancers. And as you'll hear later on from Dr. Klempner and others, not all gastric cancers are the same. So this sort of one-size-fits-all approach doesn't necessarily apply, and we've really got to actively work to find better treatments. Thank you very much.